Hello, I'm Ruth Allen, Chief Executive of British Association of Social Workers. Welcome to this webinar, which has been organised by BASWA with the AMP Leads Network, the BASWA Mental Health Policy and Practice and Education Group for Mental Health, and the Department of Health and Social Care, Office of the Chief Social Worker. So I'm joined by Claire, Steve and Mark, who are now asked to introduce themselves. Claire?
Hello, my name's Claire Barcham. I'm an AMP. I manage an emergency duty team in central London, and I chair BASWA's Mental Health Policy and Practice Group.
Steve.
Hello, I'm Steve Chamberlain. I'm chair of the National AMP Leads Network and also a member of the BASWA's Policy, Practice and Education Group.
And Mark.
Hello, I'm Mark Frewen. I'm the Mental Health Social Work Lead at the Department of Health and Social Care, Office of the Chief Social Worker.
So thank you very much for joining us. I can see we've got 430 people online, which is fantastic. We know that this is a really stressful and difficult time across social work, across mental health, and of course across AMP services. So we wanted to run this webinar for you. We've already run one webinar for AMP Leads, which we did on Friday. And what we want to do is provide you with the best current available information that we can share from our different perspectives, answer some of your questions, and thank you for those that have come in already, but please also post questions online in the white box, the chat box that you've got on your screens. We can answer some of those questions, give you the best advice that we've got, best information we've got, but we can also take away some of your concerns and questions and use them in our further work to help you get some answers to the things that we know that you need answers to, and also represent your needs and perspectives in the different forums that we're all part of. So all of us today and all the organisations we represent are committed to supporting you in practical and professional ways throughout this crisis and afterwards, and to support also your emotional and mental well-being needs. We know this is going to be very taxing for professionals, just as it is for the whole community, and of course is creating some particular issues and fears and worries for the people that we work with. So we're offering some other webinars on mental health and related topics. We are running a webinar on Wednesday on the implications of the current situation in relation to Mental Capacity Act and deprivation of liberty. We will be running a webinar on the Care Act as well and implications there, and also particularly in those regards the implications of some changes in legislation which you'll be hearing about. So today you'll be hearing about the implications of the emergency coronavirus legislation, the bill that's currently before Parliament. You'll be hearing about that in relation to mental health. We'll be thinking to be providing information and thinking about the implications for the Care Act and for MCA and other areas of practice over the webinars as well. The webinars that we're doing will all be available online in perpetuity for free. So tell your colleagues about it if they haven't been able to join. The information, the slides that we're going to show will all be there with other resources as well, so that you can have an ongoing source of information. And there's further information on the BASWA website, the Department of Health and Social Care website, Public Health England, other websites, and the resources for this webinar will signpost to those other sources of information. So that's my introduction. I'm chairing, so keeping these three in order, I'm going to try. There's lots to say. I'm going to hand over now to Claire, who's going to open with a presentation.
Thank you, Ruth. Next slide. So what I'm going to try to do is to provide some practical advice around issues that I think are a concern. Initially, it's about how you maintain your approval as an AMP, and later it'll be about some of the implications of how to do assessments in this current period. So the first thing is, I know that I've certainly been contacted by friends and colleagues who are wondering whether they could come back to practice and what the processes should be for that. So if you are a lapsed AMP, somebody who has been an AMP previously, but since 2007, you can be reapproved. And I'm sure that if you go to your local authorities, they will be very happy to see you. Things that they need to make sure of is that you are still a registered professional, i.e. you're a registered social worker, occupational therapist, nurse or psychologist. And beyond that, it's actually up to the local authority to decide how they can be satisfied that you have the competence to be an AMP. So they may do that in a number of ways. They may be more or less formal about it. It might be a legal test, it could be something else. The other thing it's worth knowing about is that if you have done your course, but you have never actually started to work as an AMP, you need to have been approved as an AMP within 5 years of finishing your AMP course. If you haven't started being an AMP, if you haven't been approved as an AMP within 5 years of finishing your AMP course, then I'm afraid you would have to retrain. The same is true if you are an ASW, but you've never been an AMP. So that covers reapproval of lapsed AMPs. Next slide. Now, in terms of people who are currently practicing as AMPs, if you are getting to a point where you need to be reapproved, the authority needs to, again, to be sure that you're a registered professional, that you've completed the 18 hours refresher training a year and that you've got the competence. But how they satisfy themselves that you've actually done the required training is up to the local authority. So there's a lot of flexibility around that in terms of what you might do, whether that's webinars like this, whether it's other training, whether it's a range of other things. So there is some flexibility there for local authorities, and talk to your own AMP leads if you're concerned about that. Next slide. Another question that comes up is about being approved for more than one authority or doing Mental Health Act assessments on behalf of more than one authority. You're only ever approved by one authority, but you can be authorised to act on behalf of more than one authority. So this does happen a lot with emergency duty teams, where you can have AMPs who are actually working for a number of different authorities. They will have one main approving authority, and then they can be authorised to act on behalf of a number of different authorities. It provides a degree of flexibility for those authorities, but the other thing is it makes clear that you will be indemnified for the work that you do as an AMP. Next slide. And it's over to Steve.
Just before you come on, Steve, can I just clarify? I should have said that we're going to do some presentations and some slides and some talking, and then we will be taking your questions in the second half. So do keep your questions coming in throughout. I was going to ask you there, Claire, what do you think in the current situation the implications are of authorities remembering about how they can work, how they can have approval across boundaries? Do you think that's going to become more important in this situation?
I think it is, because I think we will all need to work flexibly to make sure people are safe. So I think that's really important. I also think it's important because, of course, currently Section 13 means that if somebody is assessed under assessed in London and put on a Section 2 and is placed outside of London, then the authority or the responsibility for a further assessment under Section 3 would remain with the original authority. Now, there will need to be flexibility around that, and I know that we all work as flexibly as we can to try to make sure people get the assessments that they need. So I think that will need to continue.
Thank you. Right, I'm going to go to Steve now, who's going to talk about the proposed temporary amendments to the Mental Health Act in the coronavirus emergency legislation. So Steve, over to you.
Thanks, Ruth. Just to say that I'm sure many of you, or maybe all of you, will have had sight of the particular relevant amendments which affect the Mental Health Act, which is Schedule 7 of the coronavirus bill, which is today being discussed. It's receiving its second reading in the Commons. There will be committee stage and report stage after that, but as I'm sure you're aware, the government want to get this through as quickly as possible, even though there are some contentious elements in different parts of the bill. But these are the proposals, and it's important to remember that while certain elements of the bill, when it becomes an act, will come into force immediately, the Mental Health Act amendments would only come into force with specific additional commencement order from the Secretary of State. They will not automatically come into force if and when the bill becomes an act. So it would depend on how the situation develops in terms of staffing and the development of the pandemic. So they won't come into force immediately the act is passed. Can we move forward one, please? So as I said, they're temporary modifications. At the moment, it's talking about 2 years, but I understand the government has agreed to opposition suggestions that it will be reviewed after 6 months, but that's being discussed today for the whole bill. If this is brought in, basically what they're saying is that an application will continue to be made by an AMP, but it can be a Section 2 or Section 3 application, can be founded on a single medical recommendation if the AMP considers that compliance with the Act is impractical or would involve undesirable delay. So it doesn't automatically reduce the number of doctors, only if the AMP considers that the delay is impractical or undesirable. So an application founded on a single recommendation must include a statement from the AMP if this is enacted. So the AMP would have to put a statement on the statutory forms about why they consider that delay would be impractical, or unreasonable. If it's just by one doctor, it'll have to be a Section 12 approved doctor, and there will be no requirement to have had previous acquaintance with the patient. And just to say, because of this potential amendment, Section 4 would in effect be suspended for the duration of this amendment. Can we move forward one, please? So Section 5, the holding sections, the potential is here that the time limits will be increased from 72 hours or 3 days for 5.2 doctors holding section to 120 hours maximum or 5 days. And the nurses holding power of 5.4 increased from 6 hours to 12 hours maximum. Equally, an increase in the maximum time somebody can remain in a place of safety being increased under 135 and 136 from 24 to 36 hours. There is no mention about any changes to the 12-hour extension. So in theory, a doctor could extend the 36 hours to 48, but it would obviously, again, have to be related to the condition of the patient, not to do with administrative requirements or even the pandemic. There is no mention of a change in that extension, the grounds for that extension. The important thing, as you'll see at the bottom, is the assessment is completed in the timescale most appropriate for the patient. So it's not an automatic change to saying to have 36 hours available, even though it might be necessary. I suppose we're going on to talk about different ways of assessing, and we're going to be talking about that later on, but it's possible, I'll just mention now something that will come up later on, alternative ways of assessing without the traditional face-to-face, setting up video conferencing facilities may allow increased time for that. But that's just a discussion point that will come up later on in this webinar. Next slide, please. So just a quick bit about Part 3 patients. There's a change here. 35 through hospital for reports. At the moment, there's an overall limit of 12 weeks, which would be removed if this is enacted. The various powers of the court to detain an accused or convicted person in hospital, currently on the evidence of 2 doctors, will be going down to 1 doctor. And similarly, a change in the transfer direction to hospital under 47 and 48 will have an effect for 28 days rather than 14 days before the direction has to be renewed. And again, those same words come up: if impractical or would involve unreasonable delay. And just to say that there are similar changes proposed for the Scottish legislation, where they're relaxing timescales and the potential need for one medical practitioner, and the grounds are the same. Next slide, please. Right, this is my last slide, and we're going to be talking a bit more about implications for AMPs afterwards, in a wider context as well. I was just aware when I first saw the wording of Schedule 7 that the wording is subtly different to what we used to. If you think about Section 11.4, the duty to consult with the nearest relative, to Section 3. Sorry about that, it's my phone. Somebody else will answer that in a minute. Apologies. So for Section 3, we can choose not to, or we can decide not to consult with the nearest relative if it's not reasonably practicable. But the wording of this legislation is potentially impractical, and I just don't know what the difference is there. I think personally that impractical sounds more permissive and less strict, but I'm not sure. I have asked about that, and Mark is inquiring the legal eagles at the DHSC. And equally, the impracticability around consulting the nearest relative is around unreasonable delay, and the wording of this legislation would be undesirable delay. Now, we're all used to undesirable delays for years and years around lack of beds and lack of resources. But I just don't know if there's a difference in meaning between these two terms, or whether it's just different drafters pull this together. And we're wanting, because remember, this won't be enacted straight away. It'll only be enacted if the Secretary of State decides. We want to be able to get some clarity and guidance around whether there's a significant difference in the meaning of those terms or not. And just to remember, and we'll talk a little about forms as well, the legislation does say the statutory form can be modified, because of course we'll be answering questions which won't be on the form if it comes to that, just using one doctor. But the AMP will need to state the reason why only one is used if it comes to that. We're thinking that it would be handy to have a standard form of words as a header, like saying amended due to the Coronavirus Act, or whatever it's called eventually. But I believe from what I read that AMPs will need to defend their decision or explain their decision on an individual basis, normally because it was impossible to find another doctor or something like that. So I don't think we can say you can just write exactly the same on every form. It'll depend on the individual case. But the AMP will need to state somewhere on their pink form why only one doctor is used. So that's all for that. I mean, there will be implication. We'll carry on discussing this in a wider context with the rest of the slides.
Steve, thank you. And I'm going to say it again, this is not in force on the day that, if the Act is passed, which we are predicting it will be, this will only come in force if there is a subsequent decision by Minister of State. There's a commencement date for this particular part of, I think it's part 2 of the bill. So I'm just going to reiterate that. Seems really important that we go away with that clear message, but if it does come in, there's lots of implications as you've described. Mark, I wondered if you'd like to come in at that point and just say a bit about the Department of Health and Social Care and the Office of Chief Social Workers, kind of what you're doing around clarifying the implications of this bill for AMPs.
Yes, thanks very much, Ruth. Yeah, I mean, as you rightly say, the work of preparing for COVID-19 has taken over a huge amount of the Office of the Social Workers work, and the whole of the Department of Health and Social Care is pretty much gearing up to trying to prepare for this at the moment. It's obviously very difficult at the moment, very challenging, and I think the first thing I'd like to do is to say thank you to all the AMPs and AMP leads, PSWs and social workers out there who are working really hard trying to make this work on the ground, because I think we recognise how difficult it is. One of the things that people might feel is that it feels like there's not an awful lot happening in terms of AMPs, and I can absolutely understand that. The bill that went through didn't really mention AMPs, apart from in the context of the reduction in the number of doctors needed for Section 2. And I think it's fair enough to say that we weren't able to get some of the issues that we're talking about today into that bill. However, what is important for AMPs to know about is that since then, there's an awful lot working to try and make up for that since. So to give you some examples, we are currently talking with legal people in the Department of Health and Social Care around issues like the 18-hour rule and whether there's any flexibility with the regulations, and if not, what guidance can we give to local authorities, what guidance can we give shared across public health and OTs and nurses around the use of PPE. We're working with children's services in the Department of Education around whether or not we can have joint guidance for social workers across adults and children. We're working with around the legality of electronic signatures. We've just had some guidance recently from the Tribunal Service and around the use of videos. And I think the courts are coming out with similar instructions, and I think managers' hearings will probably change that as well. So all of these things are being collated and will be shared with AMPs as and when they're in a fit state to do so. So there's an awful lot of work behind the scenes, understanding the role of the AMPs. And it's not just, of course, myself and my colleagues here, Ruth and Steve and Claire, and also the chief social workers who are doing this. We have a call tomorrow with the senior people in the Royal College of Psychiatrists who've expressed wanting to help out with the situation with AMPs. We've got a number of mental health trust leads who are expressing concern about the situation with AMPs. So, you know, there's a lot of these background conversations going on at the moment. So I think that we hopefully will be working on this throughout the process of this crisis and trying to assist people on the board.
Thanks, Mark. And just to be clear, that the bill is in Parliament at the moment, and then it presumably it would go forward to the Lords. So it's still open for some amendments and some debate, even though it's an incredibly truncated process compared to any normal legislation. So people can, you know, if you are interested, you can write to your MP or write to a member of the Lords. And Baz was doing some representation about the content of the bill, but you know, it's a very tight time frame. Mark, did you want to come back in?
Yes, I just wanted to add to make everyone aware, and I'm sure that most people are, around the recent publication of the ethical standards for adult social care that goes with the COVID-19 situation, which was being prepared by the chief social workers and their team, and which is interestingly also being linked to guidance that's being written by NHS England for mental health services and has been sort of widely accepted across the whole of the Department of Health and Social Care. So I think that's going to be an increasingly important document, especially with people's concerns about human rights issues and you know, the basic rights that have been written into the Act for the mental health service users, and also in terms of the Care Act, that those ethical standards will hopefully guide us through those issues.
Thanks, Mark. Yeah, that was created with good consultation with the sector, actually. But obviously, ultimately, it's the Department of Health and Social Care. The final drafting was with the Department of Health and Social Care, as you said. So it is the NHSC guidance. I think it's very important that we think, as we go through this, about the fact that, you know, I know some AMPs are not social workers, but all AMPs will share these common values of kind of upholding rights and ethics, and that is something that we all have to really hold on to very strongly together as a profession, and then using whatever guidance is out there. And I think the ethical guidance from the Department of Health and Social Care, which is on the so it's ethical guidance for social care on their website, well worth looking at. It's actually written for the employers and for commissioners and planners, but it's very, very relevant to direct practice. I think it's important that people have a look at that, because it could be a very important document if this situation goes on as long as it's predicted to. So thanks for that. Because I think we're going to talk more about some of the specific practice implications for AMPs, things that we've been discussing that we know are issues, before we come to questions. So back to Claire.
Thank you. Next slide, please, Steph. So I'm starting again looking at some of the practical implications of the pandemic. And Steph, if you go to the next slide, please. We're starting off by thinking about how do we interview in a suitable manner where we are at the moment. Now, the first point, I think, is it's really important to think about protection for ourselves and protection for the people we're interviewing. So AMPs should be thinking about using the basic personal protection equipment, so gloves, aprons and masks, and they should be available and they should be used. I think it's important to remember that the risks might come from you, they might not come from the patient. So we need to be careful about the way in which we are conducting those interviews. I would suggest we need to be thinking more, as we always do, about the environments that we're going to be interviewing in. And there may be situations, for example, where you're interviewing in someone's home, where because of something about the home, it's actually not appropriate to try to finish the interview there. And if that is the case, you may want to think in advance about, do you have the legal basis to ask for a 135 warrant, and would it be more appropriate to take that person to a place of safety to complete that assessment? But that needs to be decided on a case-by-case basis. The bottom line is, where you're thinking about the environment, think about the social distancing guidance, think about the space, and whether or not you can assess appropriately in the environment that you've got, and can you move about. There are some good examples developing about where assessments are taking place. For example, in the area of North London I work in, they are actually moving from redirecting mental health emergencies where people aren't on a 136 but are being brought by ambulance to A&Es, away from A&Es and to a crisis hub, so assessments can take place in a more appropriate environment. And I would hope that other places will be thinking creatively in a similar way. And finally, I think it's really important, both for ourselves and for the people we assess, to appreciate the impact of the current situation and the fear and anxiety that it causes for us and other people. It's very easy to feel overwhelmed. If you are somebody who has already experiences the world as a very fearful place, and you are bothered by delusional beliefs, this may well feed into those. And we are facing a situation where our daily lives are changing, certainly for the next few months. And I think it's important to acknowledge that it is difficult, it is challenging, it is something we will get through, but it is going to have an impact on our mental health. Next slide. There's been quite a lot of debate between the four of us about the use of video conferencing and when that might be better. This is something we will be taking on, and I know Mark's had some very interesting conversations with different people where that's already been considered, for example, in terms of its use with tribunals. And I think some of the things that may become important are things like, is it a contentious assessment? If you have an assessment of somebody on a 136 and an initial triage has been done, and there isn't a need for a full assessment, or there's a different need, you may want to think about, can that assessment be done in a video conferencing manner in the future? What are the advantages for the patient? Would it avoid delay? Do you even have the equipment? And is there actually support for the person so that they can actually be involved in the assessment in the way they need to be? Equally, there may be situations where actually it would be completely inappropriate to use a video conferencing approach because of the impact on the person's mental health. And we have to think about what we will miss. So I think in each case, there will be debates to be had about when it is appropriate and if it is possible. And those are some of the things that BASWA and the rest of us are all really thinking about and pushing to get clarity about. Next slide. Steve has already talked about the idea that if this legislation changes come in, if they're relaxed, AMPs will have to evidence why they are satisfied that only one doctor is being used. So the wording is about being impractical or involving undesirable delay. Now, this is just our take on what those words could mean. So we would suggest that in practical means, in terms of availability, of actually finding the second doctor within a reasonable timescale. Whereas undesirable delay, we would say, is much more about the patient's needs. So is this undesirable from the patient's perspective, or is it just about convenience for staff? So I think it's important that there may be situations where there are advantages for the patient in actually allowing some time to pass before you do the assessment, and there needs to be a balance there. So you need to think about why only one doctor is being used and why it's appropriate. Next slide. Something that always causes me anxiety whenever I sign papers is actually getting them right. And if we are using only one doctor, the application, the wording on the application may be slightly different. The other thing is that if you're in a situation where you are approved by one authority but acting on behalf of another, you need to make sure that that's reflected on the forms. So as an example for me, I am approved by the London Borough of Islington, but I am now also authorised to act on behalf of the London Borough of Camden. There may be a situation where I go to do a mental health act assessment of somebody who isn't an Islington resident, and on that form I would say I am being approved by the local borough of Islington, but because I'm doing the assessment outside the geographical boundaries of Islington on somebody who isn't an Islington resident, that actually I'm acting on behalf of the London Borough of Camden when I complete that assessment. Now, we know that the guidance says we can amend the wording of the current forms, and Steve and I have been talking about that and thinking with Basil about developing some suggestive wording. But it is important, as we've said, to make sure that you justify in each case why one doctor is satisfactory. I think lastly, I think it's important never to forget that we have a real role in protecting people's rights. And this will become even more important if there is only one doctor being used. So whatever you do focus on the needs of the client and their rights. Make sure that what you're doing is in their best interest. Next slide. I'm going to hand back to Ruth for the questions.
Great, thank you, Claire. Mark, I'm just going to say, would you like to go to the questions now and bring some more perspectives from the Department of Health that way, so we can start hearing some questions? Or Mark, would you like to make any kind of particular commentary from the Department of Health and Social Care's perspective?
No, I think I'd best go to the questions, because most of the work that I have been doing has been responding to questions raised by AMPs and other professionals in the kind of, can we do this and is this happening frame of mind. So most of those are included in the questions that we've received. Okay, great.
So and we've got some questions coming in live, as well as some questions from before. I'm going to, can I just ask this one to all of you then, anybody who'd like to pick it up? It's a question about how are AMPs managing to carry out assessment of need where there are positive cases of COVID-19. So just kind of perhaps any examples or any thoughts about how AMPs can manage that acute situation, which I'm sure is affecting people's practice. Claire, would you like to come in? Yeah.
This is certainly happening already. I was on duty over the weekend and there were assessments going on where people were concerned, obviously. And I think what you need to do is you need to be thinking about how you access the gloves, the aprons and the masks, so that when you're going in to do those assessments, you're doing them as safely as you can. And that you're conscious of the environment, as we said, and the impact of how you're having to assess may have on people. But it's things that we can explain to people as part of the assessment, in the same way as we explain why we're doing things at the beginning of an assessment. So I think taking it one stage at a time, it's worrying, but it's manageable.
And that point about the fact that we might be the risk is really
Yes.
it might be a very important part of the explanation if we're gowned up and we're not looking like we usually do. Mark, did you want to come in?
Yes, I just wanted to talk about some of the practical issues around getting hold of PPE, because I think one of the things that worries.
So that's the personal protective equipment, just to be absolutely clear. Yeah.
That's the personal protective equipment, which obviously we're now talking about PPE as if we know what it means, whereas the day before yesterday I don't think we knew that. But AMPs are concerned that they're not being mentioned in the large numbers of conversations that are happening online, on social media, or within organizations. And I think that's an absolutely fair point. In actual fact, when you look at the small print of some of the things, it does say access to health services, care homes, and social services departments. So for example, the other day, there was something done by the Department of Health and Social Care and announced by the Secretary of State around abilities to try and get hold of PPE equipment. And it was particularly advertised as something that was for care homes. And what we're trying to do now is to find out whether that means that social workers can use it as well, because it clearly states on the advice that comes with it that it's for social services departments. The other thing that's happened today is that there's a big rush to get PPE out to NHS trusts, including mental health trusts. Many of our AMPs and social workers work within mental health trusts. Obviously, they're not being mentioned in all of the stuff that comes out about this. So we're trying to organise as much as we can to get people to remember that when they're ordering PPE, they need to do it for AMPs as well. In terms of the use of it, we're also working with the Royal College of Nursing and OTs and others to try and look at what do we mean by the use of PPE, because obviously an AMP assessment is a close and personal assessment in someone's house, often, or on a ward. And the advice that's being given to nursing staff at the moment, who obviously are much more likely to do very close up and intrusive assessments, is that PPE should be worn if you're within 2 meters of somebody. And obviously 2 meters is quite a long time, quite a large area in terms of someone's house, and so we want to try and get some guidance out that's specifically around AMPs, and I think community psychiatric nurses and others who are going to people's houses and talking to people, but not necessarily interacting with them in a physical way.
Thank you. There's a comment from somebody online about how we need to perhaps be encouraging people to consult the health and safety officers, their trade union, professional body. So I'm just thinking about what we might say to social workers about, raising questions in different ways, proper constructive ways that might help if they're not getting access, perhaps, or they're not clear about protections and health and safety at work.
Yes.
Steve.
Can I just say that going back to my role, I mean, that I think that's a crucial role of the AMP lead. The majority of local authorities do have AMP leads. There's a handful that don't have formal leads, but the management, and also we've talked about this, haven't we, about BASWA discussing directly with ADAS about the need for this and putting pressure in as many points, leverage points as possible. But your AMP lead or your managers should be taking that straight up the line about the need for the equipment to be available. Whilst BASWA can't actually sort of deliver stuff out to individual local authorities, there's various levers that can be pushed, buttons pushed, levers pulled, or whatever, around pressing people to go down that route and organisations to go down that route.
Yeah, I suppose what all of this raises is the fact that AMPs, social workers in so many contexts, work in multidisciplinary interagency contexts, and it's making sure that the planning for the multidisciplinary and interagency response to needs, whether it's mental health or something else, is really taking account of the social workers and in this case the AMPs in that context. We've had a question in asking, saying that somebody's saying that an AMP saying their local authority is given different guidance from that received from central government. making it difficult to practice in even more challenging circumstances. So, I mean, how do we address the fact that the AMPs might be, and social workers more generally, might be getting some conflicting local and national interpretations of good practice? Mark, do you want to come in?
Yes, well, I wanted to make a point, and I think this is something that you and Steve and Claire and I have really talked about in detail over the last couple of days, is that an awful lot of the things we're discussing here are the individual responsibilities of local authorities and NHS trusts. And whilst centrally it might be helpful to have guidance, even if guidance comes out, it's often the individual responsibility of local organisations to implement it. And so, therefore, I think it's really important that that we have this consistent approach from local authorities in terms of how we are, and that local authorities talk to each other through ADAS and the LGA, and have these approaches, because in many ways it is their role rather than the role of the centre to tell them what to do, if you see what I mean.
I think it will be helpful when some of the guidance on some of the practices, such as guidance for home visits for social workers, which Baz was working on with some other professional organisations, is available. It won't answer every question for every circumstance at a local level, but I think we have seen that there are gaps. Yeah, there are gaps. And just to say that the ethical guidance that's come out, which is for the employers and the managers, it is about the ethics of making sure that the workforce is protected. So that is in there as well. So it's important. Do have a look at that guidance, because that's something else you can talk to your manager or your AMP lead or your colleagues about. Claire, yeah.
I just wanted to say, I think it's important, because the advice nationally has developed over the last 10 days, that if you're getting guidance which doesn't seem to chime nationally, do go back to your AMP leads and do ask for clarification, because it may be that the advice that you've found has been superseded by something else. As Ruth says, I think the important thing is that we are protected as AMPs, but in order to protect other people. So it is important to make sure we do have access to the right equipment, so that we can do our job, because actually our job also protects people.
Yeah, thank you. We've had a question in just about there being enough AMPs, and I guess this raises the question of whether or not the workforce will be depleted, maybe sort of people coming and going and being able to practice if they themselves contract the virus, become unwell for periods. Are there any thoughts about, that's not something that can be magically changed, but there are provisions, as Claire was outlining, for people to be brought back into the AMP workforce in a relatively short order, although that's not, again, that has some difficulties. But I wonder whether anybody wanted to comment on that. And there's a supplementary question within that, is should we be encouraging nearest relatives to make applications? Thought.
Yeah.
Anybody want to have a go? Yeah, Claire.
I don't think it's fair to be encouraging nearest relatives to make applications. I think that should be a last resort. I think we should be actually talking to our colleagues in the Department of Health and Social Care and pushing for technological changes that might make it easier to do some of those assessments. Clearly, a nearest relative can make an application, but I think to presume that that's the way we should go is riven with challenges, because that's something that's going to be with that person for the rest of their life. They had to sign the paper.
Yeah. Steve, did you want to come in?
Yeah, just about enough AMPs, not about the nearest relative, but I don't want to take your job away from you. I'm aware of the question about fast tracking AMP trainees who haven't actually been through the exam board process, and that's something I think that we've been talking about, and potentially whether that's one of the flexibilities, because the regulations, I think, say that the person has to have completed the course, and we've always interpreted that as being gone past the exam board, but we haven't got a definite answer for that yet, and that's only a very small number, I know, and some people may think that's just a drop in the ocean, and it's not an easy answer in terms of having enough AMPs in terms of potential depletion. We all know from the Skills for Care survey that at the best of times we're struggling with numbers in a lot of places. So it's not an easy answer, apart from potentially bringing back people who are retired or fast tracking people who have completed their course, but the exam board hasn't sat yet.
But there's something in this about recognising we anticipate the situation going on longer than we might have done even a week or two ago. So it's worth organisations thinking about whether they can bring people through, before the exam board stage if they've finished their training, and then support them into practice. It's actually worth thinking about that for kind of the medium term, because this could go on. This isn't sort of a fly-by-night thing, or most obviously. Claire, did you want to come back in?
I did, but I can't remember what I was going to say now, so I can stop.
Okay. There's a question here about that we've had about could there be more rigorous triaging for the need for mental health act assessment? I mean, I think there's quite a lot of triaging in most places anyway, but I wonder if people had any thoughts about that, Mark.
Yes, well, I totally agree with that. And of course, when we look across the country, there's all kinds of different brilliant examples of how people work together in partnership that are way too huge for us to go into here. But I think this is the time for health and social care organisations to work out how they can work flexibly together to be able to look after each other. And if you look at the situation with Claire's situation of working out of hours, that you have a number of workers in an area. It might be a 24-hour AMP service, it might be an emergency duty service, and it might be a crisis team within the Mental Health Trust, and they might all be integrated, and they might all have police and AMPs and nurses within them. And I think it's time for us to think about how we put those people together and be able to work out, can we avoid people coming into AMP duty? Can we divert people and use the least restrictive principle? And if people are coming into AMP duty, how can we support each other to be able to do that work, considering that everybody is going to have a loss of staff in those groups?
Okay, Claire.
Something that we already do in my team, because we've got a couple of large police stations in our area, is where we have a situation where there is somebody in custody, they've been arrested, but there are concerns about their mental health. If there isn't a liaison forensic person there at CPN or a social worker who can do an initial triage, we actually ask a Section 12 doctor to go and do that triage first. Because that means that unless it's very clear that the person is really unwell, in which case we might have a discussion with custody about, do they want to actually move that person out of custody and consider using 136? If the Section 12 doctor goes in, it means that that person can move through the system more quickly. So they can actually either, we consider, say, right, we need to do a full mental health assessment. Do they need to come out of custody to 136? Alternatively, if that initial assessment says, no, we don't think that they are actually detainable, they can actually progress through the mental health, through the criminal justice system. There is also one other thing I wanted to sort of reassure people of, being in London. And one of the things that has happened initially, at least in EGT, is we have seen fewer urgent and emergency mental health assessments in the last couple of weeks. So it's not to say that this is not affecting people's mental health and is not going to come up in the assessments we do, but in terms of the numbers of 136 requests that we're getting and the requests from A&E or the new crisis centre or the police, that's gone down, which has given us a little bit of an opportunity to catch up. So it's worth knowing that.
Can I just ask, do you think that people staying at home and not being outside, not on the streets, is having an impact on that? I don't know if you can even answer that, but I just think one of the things that we broadly are going to be aware of is changes in behaviour caused by the situation that we're in, the emotional impact, but also the behavioural changes of impact of different guidance that we've got, and it's just affecting work in a whole range of different ways. But it's interesting. Steve, did you want to come in on that?
Sorry.
You had your hand up.
Just a little quick one about I've done a few reviews recently over the past few years of AMP services, and this isn't widespread, but it's not that uncommon where there's a moan from the AMP service about them being used as a dumping ground, quotes unquote, where people just haven't been seen recently. I suppose it's an opportunity to, in terms of triaging, going back to the question about strict triaging, is to talk to the crisis teams and the CMHTs. I suppose it's management and AMP leads to talk to them now about the clarity about the absolute need for an assessment rather than just a go, look, see, which sometimes I've heard repeatedly, but not all the time, but sometimes I've heard the moan about AMP services being used for that purpose.
Yeah, okay. Mark, yeah,
just a quick one. That if an area doesn't have an agreement with the CCG and the Mental Health Trust around availability of Section 12 doctors at a reasonable hour in the daytime, now is a good time to try and put that in, because I know that is a major issue in some areas, not all, on AMP stress, is when Section 12 doctors are not available during the daytime and only can come out after 5 or 6 o'clock. You know, and then having to get another Section 12 doctor at 5 or 6 o'clock. Now, obviously, if you've only got one, it would be better if they were available at 11 when the AMP is actually ready to go out, and keeping those things under control. Some areas have got really brilliant agreements to allow that to happen, and others haven't.
I'm going to go on to another question. I think kind of has some continuity about that, because it's about AMPs being left with it all. So the idea that it's the AMPs who are left holding all of the different things, still being left to coordinate everything, and that would be the case if the new provisions of the proposed coronavirus bill came in. Would AMPs still be left doing the coordinating? And actually, I guess there's buried in that are questions about the impact of on bed availability of the current situation as well. Just wondered if anybody wanted to pick up on that. Claire, did you want to come in on that? Yeah.
Yeah, I think this is a really, really important point, and I think it's really important to be using the systems that currently exist in terms of highlighting the risks here. So every local authority has responsibilities around emergency planning. So locally, everything's being coordinated via an emergency planning group, and senior managers need to be able to highlight the risk that exists. And it needs to be owned on a multidisciplinary basis. We need to make sure that there are Section 140 policies, so people don't get stuck in situations where they know somebody is so unwell but they can't submit them. There needs to be clarity about things like access to alternatives to ambulances to actually transport people to hospital. We know it's possible to do that. We should actually be encouraging CCGs to release the money to allow those alternatives to be used more than they are at the moment. And we need to be making sure that that the risk of sending people out of area is highlighted. How can we get more beds locally for people so that they don't go miles away, because it's not good for them, particularly in the current environment, and it makes it much more difficult to follow them up. So use and encourage your AMP leads to use the risk systems that are in place to highlight the problems for AMPs and for the mental health system.
Okay, thank you. We've only got sort of 5 minutes left. I'd like to just try and do a couple of other questions quickly, because we've had lots, and there's just a couple of other different topics that I think are important and interesting. They're all important and interesting, by the way. I'm sorry we won't be able to answer all of your questions, and I'll come back to that point at the end. Question about what public liability protection will AMPs have if they break into someone's self-isolation in their own home? Steve, do you want to pick up on that?
Yeah, well, my understanding is the same as normal. If you're working on behalf of, approved by and or working on behalf of a local authority, then the vicarious liability rules stand as they always stand. And if you're working, if you're doing something in good faith, then you should be protected, and any concern would come back to the local authority, who will hold that indemnity.
It's a good point, though, isn't it? It's a very, serious thing to be going into someone's house if they think they're protecting themselves, and you go in. So it's an important question to ask. Sounds like the team should have an understanding of that, and it's something that we probably need to be aware of. It's in no sense a neutral act in this circumstance to go into somebody's house if they're looking after themselves in that way. Steve?
I suppose, just to reply to that, I suppose it just reminds us that we've been doing this for however long we've been practicing, going into people's houses using a warrant, breaking in, and that is by no means a neutral act. We've got additional risks now to us and to other people, but I suppose to me it reminds us of the draconian powers that we do have, that we sometimes use.
Yeah, thank you. One more quick question that we've talked about, and it's come up in a range of questions that have been asked. Access to IT equipment and online connectivity, to use remote joining for assessments or for interviews. There are practice and ethical issues, and there's also some very practical issues I think have come up with people saying they don't really have good access. Have any of you got any just quick comments on that? Because digital communications has become so important. It's really emphasised that, hasn't it, in this situation? Steve, again, yeah.
I think my thinking over the past week, even over the past 4 or 5 days, has developed rapidly on this. I think we've always been very anxious about this. Nobody's done a proper pilot on it. I think we need to be moving rapidly towards the stage of trying to get this as much more regular, if at all possible. Yeah. It'll be incredibly difficult in people's own homes, but significantly more, less complex, without being, still being complex in hospitals, places of safety. It won't be incredibly expensive for organisations to buy a tablet, and it's complex, and there's people aren't used to doing it, but in terms of the overall money involved, it's not a lot of money to try and set that up rapidly. I think we ought to be moving rapidly towards that, and really thinking the other side of the coin is the person at the other end, the patient, would need to be supported in some way in 99% of the time. So that's an issue about who might be able to support them. But a Section 3 assessment or assessment on the ward, they may be able to be supported by a nurse, for example. I think we ought to be thinking much more actively about this and using it much more, notwithstanding the fact that the issues we haven't had the chance to go through the issues ethically over, because things are moving too quickly.
Thank you. Mark?
Yes, I totally agree with what Steve has just said, Steve. And I think, from our point of view, we've got to try and compromise in a way that reaches the best possible outcome, mostly for the people who use our services, but also for us. An awful lot of people who use our services are using FaceTime and Skype every single day with their own families, and possibly think it's a bit weird that we don't. On the other hand, there are people that we work with who are incredibly vulnerable and have absolutely no access to the internet whatsoever, and need looking after in a very different way. So I think we need to try to be as flexible as possible in terms of doing this. But if we can, my own personal opinion is that if we can assess somebody using FaceTime, that doesn't terrify them because we've come in equipment, or make them worry because we're breaking their isolation. Although that's not good enough in terms of in a suitable manner, it seems to me that it is better than some of the other options.
And it might be legally compliant. I think that's the key issue, isn't it? Yeah. Thank you. We're going to have to end there. Thank you. Thanks very much to Claire, Steve, Mark, panelists, for presenting and answering all those questions. We've had lots and lots of questions. We haven't been able to address all of them. We've tried to pick up on some themes that have been common across a number of the questions. We will upload some frequently asked questions, information and guidance to go with this webinar. Thank you again. Over 430 people stayed with us throughout this whole webinar. Please let your colleagues know this is available on the BASWA website going forward, and please look out for other resources, other webinars and other resources to help you through what we know is a really difficult time. I hope you've found this helpful, and again, as we said earlier, thank you very much for all that you're doing. Bye-bye.